COVID has generated a huge amount of research. I think if you comb through the published literature now, we're in the tens of thousands of published studies just since last year. So it really is phenomenal, and it's even taken out a lot of the research machinery in many countries.
The first patient that actually came into the intensive care with COVID was not critically ill. At that particular point in time, there was not much known about the disease. There was a lot of fear. There was a lot of apprehension. Not much had been researched about how it presents. So a lot of persons did not really know what to expect. All that the person knew about it at that point in time were the reports that we had seen from places like China and some other parts of the world like Italy, Spain, and the UK, where a lot of the reports were very negative, and what we saw were a lot of persons who were dying and hospitals that were overwhelmed, and so we weren't quite sure what to expect. Fortunately for us, the very first patient that presented was not very ill, and so she went through quite uneventfully. But it was very quickly followed by a number of quite ill patients. And so the first critically ill patient, we do still remember those patients quite well. And the challenges with managing them, there was not a lot in the literature at that time as to how you manage the COVID patient. And so we basically, fortunately, because of the age of information and knowledge sharing, we were able to actually piggyback on the experience of other centers. We had colleagues in other centers that had managed COVID, and so we looked at some of their protocols. We made contact with some of them, and so we were able to build our own system. And over a period of time, we began to see the uniqueness of our own patient population.
We have two teams that we've put together that I believe has guided our thinking. One is what we call the COVID-19 task force here at the University Hospital. A multidisciplinary group of clinicians, nurses, engineers, administrators, financial people who put together the entire response. But we also have a governance team grounded in infectious disease, infection prevention, and occupational health. And we're one of the only institutions that has this combination and has occupational health as a separate profession and department within the region. And they were able to leverage their experience within infection control, infectious diseases, and in occupational health to first of all determine how we should treat and cohort the patients, but importantly, how we should protect the staff so that we have a response as long as we have seen, and the response is still sustained without the hospital collapsing. What we learned early is that COVID is a very lonely disease. I believe from the days of Mary Seacole, Jamaican nursing, known worldwide for its high quality care, its compassionate care, the ability to interact with our patients. The way Jamaicans live, that came under threat. Because no longer could nurse come by and just interact with you and doctor chit chat with you and explain what was going on. Because they had to put on the space suit, the PPEs. So we had to invest significantly in infrastructure and connectivity with digital cameras, with monitors being connected to our EICU, with communication systems, with laptops and iPads to communicate with families who are outside and cannot visit their loved ones within the hospital. And that had to be an evolving response. And our patients actually taught us a lot there. They want to speak to their families. How can we solve this? So we go to IT and we said, look, we have to find a way, and it can't just be a cell phone. You know, we have to ensure that the connectivity is comfortable and is clear. And so we evolved that system of care to include our EICU and our communication system.
COVID is not a disease of lifestyle. It's not a disease of lifestyle, it's an infectious disease. But we've seen that the persons who have suffered more have been persons who have certain kinds of conditions, that some of which have been associated with lifestyle changes. Hypertension, diabetes, obesity, etc. These are lifestyle diseases. Not just only lifestyle diseases, but I mean, there is a significant role in lifestyle. So the push towards encouraging lifestyle changes that promotes a healthy lifestyle needs to continue. We've seen that. I mean, COVID is not the last of the pandemic that we have seen. And over the years, in terms of the pandemics that we've seen, over the other epidemics or pandemics that we've seen in the last few years, we've just seen this particular pattern. In 2009, 2010, we had H1N1, and up to about 2011. And, it wasn't too bad for us, but prior to that time, in 2003, you had the MERS and the SARS-CoV-1, the original SARS-CoV-1. And so we've seen that almost every 10 years or thereabout, we've seen a pandemic. Prior to the 2000s, we were seeing pandemics maybe every 100 years. And so we've seen a pattern. And based on WHO projection, COVID is not the last of its kind. So there are other viruses that perhaps may emerge, whether zoonotic or otherwise, that may emerge. But one thing has been consistent in all of these: they just tend to be worse in persons who have comorbid conditions. And we know that there is a lot of association between comorbid condition and lifestyle. So we need to encourage healthy lifestyle. That is one aspect of it. The other aspect of it is capacity building in our health institution. We need to build capacity in our system. We cannot wait until we have a pandemic to build capacity. That's just too late at that point in time. It's just like going for a game and you're practicing on the pitch. It just doesn't work that way. And so there needs to be a focus on building not just capacity, but also building excess capacity into the system to be able to respond to things like epidemic or pandemic, so that you are able to at the time of need. And that's something that we really need to pay a lot of attention to. Jamaica has done fairly well compared to many other countries in the fight against COVID. And what has carried us to a large extent in doing as well as we have done is because we've had a very good public health system. And that public health system has been built over the years. Over the years, a lot of pioneers in the public health institution have built a public health system that has served us well. So if you look at the WHO list of countries, when they look at life expectancy, infant mortality, etc., these are indices that you use to measure the health status of country. Jamaica has done quite well. And that's because the public health system has worked for us.
What particularly about the system?
We have public health nurses, we have public health inspectors. At the grassroots level, things have been built into it, so that you realize that our immunization program in Jamaica, for example, is one of the best in the world, right? Because our infant immunization program is compliance is very, very high. They're in the 90s%. And so because that framework is there, so they were able to use it in the middle of this pandemic to be able to reach persons at grassroots level, not just only for education and information purposes, but also for contact tracing. So we do have one of the best contact tracing also in the world, because every patient is traced to the best of their ability, and efforts are being made, and so it could have been so much worse.
How has the university hospital been able to respond to its own people before they even respond to the public?
A preemptive strike. So we felt that the team needed support, and so as a strategy from early on, we put together a support group headed by occupational health, but also with our lead psychologist and our lead from the Department of Psychiatry and Community Health. And they put in place a support team. We also knew of burnout within the medical space, And so prior to COVID, we had started doing surveys and looking at this in an active manner. And so we were able to ensure that even before we got our first case, that we had a team that would support those who were working with COVID, support those who would seroconvert and become positive with COVID, but also a team that could support our patients even as the patients were sick.
I try to remind people we've been fighting two epidemics, right? The epidemics of NCDs, non-communicable chronic diseases. That's your diabetes, heart disease, hypertension, chronic kidney disease with renal failure, non-COVID pneumonias and infection. So those things is a pandemic already and an epidemic here in Jamaica. And now we have COVID also. So yes, that's some of what I've been doing.
What goes into the development of the protocols for treatment? What if you could be...
Protocols for treatment for COVID, yes. So yeah, what goes into development, the unique thing about this disease, it's, again, we are just 1 year and 6 days from when it was first announced that it even existed. So there's been a lot of learning on the job and experiences that have had to go in. So in terms of developing protocols, we certainly listen and collaborate extensively with our partners up north since they've seen persons before we have. So guidelines and experiences through colleagues in infectious disease and public health in the United States, in Europe, and out of China. So especially the CDC guidelines, the WHO as a strong partner with us here in Jamaica. And we do take into consideration what their experiences have been. We use that as a backdrop, as well as emerging data that comes out in the literature. There's probably not a day that goes by that there's not a new study that talks about COVID comes around. So we incorporate some of those. And then of course, our own experiences here, we've been incorporating those too into as we develop these protocols, almost in a sense to Jamaicanize it or Caribbeanize it, because we may have certain unique things, especially in how we have also healthcare delivery, what we can and cannot deliver. Many of us might remember when this first came out, we spoke about the novel coronavirus, novel being new. And it was new to us, we never knew about it before, but more importantly, it's new to our immune systems. Now, you and I, over the course of time, have had multiple exposures to other respiratory illnesses. Many people would have gotten maybe another form of coronavirus before this, what we may call the common cold. One of the reasons why it's just a mild disease is that most of us, our immune systems, have some ability to fight against the virus and to conquer it. So we might get sniffles and a little sore throat, etc. But this virus, which is new to our us as humans, we have not yet learned to develop our defenses against it. And so therefore, its ability to spread is rapid. You and I catch the flu, but maybe I'm deathly ill and you are doing relatively well. And the same thing is also true also in corona. That it also depends on our ability to respond. What also makes it a bit more deadly for us too is obesity. The higher your weight or body fat, the more likely that, for reasons which you don't quite fully understand, it makes it more devastating to us. Obesity itself is what we call an inflammatory condition. Remember I mentioned inflammation with corona before, right? But in obesity, there's a low level of inflammation that occurs, and also a level of dysfunction of many organ systems, and therefore such persons become more susceptible to the effects of COVID. So we have a problem here in Jamaica, and therefore and this is one of the remember I told you about 2 pandemics that we're
Yeah.
fighting against, right?
NCDs,
So the NCDs, so obesity and our lifestyle pushes the non-COVID pandemic, but it's also pushing a little bit of the COVID pandemic in the sense of our response to whenever we become infected. So the wonder to me is that we're not worse off, because Jamaica has high rates of it, and certainly here at the university, and it's also throughout the Caribbean, there's been much data. We participated in publishing some of these studies of our high rates especially among Jamaican women, but among Jamaican men too. So I'm just amazed that we have not been more sick, but I'm also very thankful.